Well, thanks for inviting me, and I wasn't even sure how many 40 people are. Like, that's how little I've gone out of the house in the last couple of years. This is about it. So, and it's these ceremonial surroundings, and okay. Well, thanks for having me. I'm not a clinician, and I'm not in the kind of. I really appreciate the invitation to think about the kind of functional organic distinction in relation to the work that I do, which is more ethnographic, anthropological. And the title of the talk is From Making Space to Space Making, Psychedelics and the Functional Organic Distinction. And I wanted to start just by mentioning a couple of things at the outset, that in addition to the academic work that I do, I just kind of recently started working as a kind of scholar in residence with this drug development company, Tactogen, that's a public benefit corporation in the US, a social enterprise equivalent here. And the remit there is thinking about how we can design clinical trials in more expansive ways and more in line with social justice principles. And that's in relation to psychedelic clinical trial design, which is a really kind of interesting, challenging area for thinking about how we do clinical trial design. So if anyone's actually interested in that, then do get in touch with me about that. I'm also an ambassador to the Fireside Project, which is a psychedelic peer support telephone line for people who are tripping or have tripped or have held people in spaces where they're tripping and want to speak about it. Okay, so I'll give you my talk. With a rising interest in psychedelic substances in the global north and psychedelic-assisted psychotherapy as a novel psychiatric intervention, more attention is being given to related ideas of spiritual emergency, awakening, and crisis. I'd like to draw on some of the history of the term spiritual emergency and its explicit articulation through the functional organic distinction to understand better what that distinction has afforded those invested in spiritual emergency in related terms, and to consider how these terms may land differently in today's revival of interest in the therapeutic potential of psychedelic experiences. Psychedelic drug experiences have long held psychiatry in thrall as organically induced altered states evocative of psychosis, dissociation, trance, and mystical experience. The drugs have had an uneasy relationship with biomedicine, both in the first wave of research ending around 1970, and again in today's 2-decade-old wave of research, albeit differently in each case. When LSD was first intensively researched in the 1950s, dominant psychiatric understandings of madness were psychoanalytical. As Patrick Barber, Erica Dick, and others have documented, when the psychedelic drug mescaline gave non-psychotic researchers, Humphrey Osmond and John Smithies, similar visions and affects to those reported by psychotic patients, Osmond and Smithies hypothesized in 1952 that an endogenous analog of mescaline could be the organic cause of madness. Along with securing an organically framed understanding of psychosis, this justified calling mescaline, LSD, and similar substances psychotomimetics. Yet just a few years later, Humphrey Osmond was exchanging letters with the writer Aldous Huxley, agreeing that they needed a new term because psychotomimetic wasn't correctly capturing the experiences engendered. Instead of being framed as producing organic poisonings, they sought to articulate psychedelic experiences through spiritual and mystical ideas, taken in large part from Eastern philosophies, as psychedelic, or mind manifesting for Osmond. And that's the famous line from a poem that he wrote to Aldous Huxley. Or working to open the brain as reducing valve in Huxley's formulation. This transformation and transvaluation from psychotomimetic to psychedelic is celebrated as a key moment within Western countercultural law. As I hope to show, mystical, spiritual, and transpersonal traditions continue to avoid, resist, and exceed the biomedical reductionism that has so often cast psychedelic experiences as organic disruptions of a psychotic nature. Nested within a much longer history of experimentation in American mysticism, the Californian Esalen Institute acquired an iconic status during the 1960s counterculture as the geographic epicenter of the human potential movement. Named after a local Native American tribe, the Institute was set up by two Stanford psychology graduates, Dick Price and Michael Murphy in the early 1960s as a think tank and small school, just as Lang's The Divided Self and Saz's The Myth of Mental Illness were being published. Questions of madness were central during Esalen early years. Price had had a breakdown and been admitted to a psychiatric hospital from 1956 to 1957, where he received multiple electric shocks. He described these experiences as formative in his quest for a space to hold the spontaneous healing experiences that psychiatry was mistaking for movements towards disease. During the height of the counterculture, the west coast of the US had seen a welcome reception of Lang and Gregory Bateson's ideas of madness as a kind of inner journey. Daniel Burston notes that Lang was the most widely read psychiatrist in the world during the late 1960s, with his famous book, The Politics of Experience, selling more than 6 million copies in the US alone. When Stan and Christina Groff arrived at Esalen, it was an Esalen moved by both Lang's recent visit and a wider opposition to biomedical psychiatry's casting of madness as essentially meaningless. Living and working at Esalen from the mid-1970s through the 1980s, Stan and Christina Groff insisted that psychedelics were powerful amplificatory tools for psychiatry, akin to the telescope in astronomy and the microscope in biology. Stan Groff was drawing on a long experience of working with psychedelics, personally and professionally, both in Prague, where his first LSD experience as a volunteer in 1956 had revealed to him a realm of spirit transcending the constructs of space and time, and later at the Spring Grove State Hospital in Maryland. Adapting Freudianism to incorporate and expand upon Otto Rank's emphasis on the trauma of birth, Stan suggested the psyche carries the traces not only of early childhood, but the perinatal realm in utero. Christina Groff, née Goodale, had been advised to meet Stan by her teacher, the by then famous comparative mythologist Joseph Campbell, to help counsel her through what she and Stan would later describe as a spiritual emergency, culminating from the birth of her first 2 children, a yoga retreat, and a car accident. At Esalen, Christina Groff founded the Spiritual Emergency Network in 1980, with funding and support from Dick Price, connecting people undergoing psycho-spiritual crises who called their hotline with professionals in major cities across the country who were able and willing to help. By 1989, there were approximately 150 calls a month. Religious studies scholar Jeffrey Kripal writes, Westerners were undergoing intense spiritual experiences that could not be understood, much less appreciated, within their own cultural frames. In colloquial language, they felt they were going mad, when in reality, according to the Groffs, they were often undergoing a kind of spiritual rebirth that was best understood within the vocabulary and categories of the Asian traditions, inevitably in one of their tantric forms. Stan Groff and other young researchers by the 1980s had nurtured a distinct subfield of psychology, transpersonal psychology, which allowed circumnavigation of the return of biological approaches within psychiatry, affording a degree of freedom to the study of psychedelic experiences and spiritual emergencies through psychology. In seminal transpersonal psychology literature co-authored at Esalen, Christina and Stan Groff coined the term spiritual emergency to refer to certain experiences that were being mistaken as psychosis in mainstream psychiatry. The first diagnostic task, they explain in their 1990 book, The Stormy Search for the Self, is to exclude any medical condition detectable by existing clinical and laboratory techniques that could be responsible for the perceptual, emotional, and other manifestations involved. The psychological symptoms of these organic psychoses are clearly distinguishable from functional psychoses by means of psychiatric examination and psychological tests. They go on, the next test is to find out whether the client fits into the category of spiritual emergency. In other words, differentiate this state from functional psychoses. There is no way of establishing absolutely clear criteria for differentiation between spiritual emergency and psychosis or mental disease, since such terms themselves lack objective scientific validity. The task of deciding whether we are dealing with a spiritual emergency in a particular case means in practical terms that we must assess whether the client could benefit from the strategies described in this book or should be treated in traditional ways. For people to be having spiritual emergencies, it was crucial that they had insight into the psychological nature of their distress rather than projecting it out onto others or the world. and that they felt themselves to be undergoing teleological processes. Stan later described spiritual experiences as belonging to a broader category of holotropic states, states that tend towards wholeness, or spiritual emergencies that lead to spiritual emergences, including through psychedelic and breathwork facilitated states. We can put spiritual emergencies alongside other terms in the 1960s that performed a similar function of distinguishing extreme states that were positive forms of madness with potential from irredeemable states of psychosis, including Boyson's notion of certain pathologies as attempts to solve problems of the soul, Dabrowski's notion of positive integration, Ellenberger's idea of creative illnesses and balanced distinction between malign and benign psychoses. For Stan Grof, psychedelics could even be of use in spiritual emergencies to help accelerate and complete the journey rather than prematurely closing it down. In their 1989 collection of essays, Spiritual Emergency, Lang's key text on transcendental experience that features in the Politics of Experience is reproduced for the fourth time, as far as I can tell, alongside seminal statements by other key Western luminaries of anti-psychiatry, psychedelia, and Eastern traditions, such as John Weir Perry, Ram Dass, and Jack Cornfield. A now iconic quotation from Joseph Campbell serves as the epigraph for the Grof's first chapter. The mystic, endowed with native talents and following the instruction of a master, enters the waters and finds he can swim, whereas the schizophrenic, unprepared, unguided, and ungifted, has fallen or has intentionally plunged and is drowning. The Grofs traced how a kind of recuperation of putative psychosis was possible. For the Grofs and subsequent proponents of spiritual emergencies, analogies between psychedelic and psychotic experiences were pointing to a prevalent misdiagnosis. Meanwhile, no consensus was sought on the prevalence of, or indeed how else to approach, the residual category, i.e. those considered not to be misdiagnosed. Conceptually, the Grofs attempted to make the term spiritual emergency palatable to the psychiatric orthodoxy by recalling the difference between organic psychoses and the more mysterious remainder that had long been categorized as functional forms of psychosis. Building on the history of differential diagnosing, the Grofs sought to clear a space to specify spiritual emergencies while enabling the identification and treatment of organic conditions to siphon off any problematic false positives. Clearly identified organic changes such as intoxication, including with psychedelics, or disease or injury, could then be viewed as triggering spiritual emergencies, wherein the latter contain their own directionality and distinct trajectories of resolution. In previous attempts to introduce such ideas, we can find risks of sliding into what the transpersonal psychiatrist Tim Reed has recently dubbed a fundamentalism. For instance, that all so-called psychoses are actually spiritual emergencies. Burston suggested that in the second half of the 1960s, Lang would respond that most psychoses entailed reluctant explorers who had gotten lost, but given the right conditions might still find their way. While once the tide had turned away from anti-psychiatry in the 1970s, Lang was more cautious, estimating publicly on several occasions the odds of spontaneous recovery for the well-supported at 50% or less. I suggest that maintaining that spiritual emergencies need to be distinguished from organic and functional psychoses was useful to justify the time, space, and resources to work in specialist ways on the experiences that qualified as such. Leaving the fate of psychedelic drug-induced states to be negotiated elsewhere, largely based on what William James called their fruits, whether they are mystical insight, re-enchantment, health or productivity, or prolonged bad trips or flashbacks. Spiritual emergencies are understood as their own family of experiences, only potentially triggered by psychedelic experiences and not to be confused with functional psychoses. Over time, this has served to build a wall between actual madness and potential spiritual emergencies that I suggest is unjustified and unhelpful and itself needs breaking down. Psychedelic experiences, and in particular LSD, had given the Grofs maps with which to work with expanded states of consciousness, leading to the quinning of spiritual emergencies, which could then be studied and treated more or less independently of the psychedelic movement that birthed the term. By positing their term spiritual emergency as a set of misdiagnosed syndromes alongside the set of functional psychoses, the Groffs made space to ground alternative possibilities, indeed possibility itself, the idea of a psychotic-like experience as transformative, leading to growth or a spiritual emergence. Contrasting spiritual emergencies with organic and functional psychoses required criteria for how to sort actual cases. Invited to Esalen by Price, David Lukoff met the Groffs in 1981 and began helping out with the Spiritual Emergency Network. After co-organizing a conference in 1989 where 500-odd transpersonal psychologists eagerly discussed ideas of spiritual emergency, the organizing committee agreed that while the event was successful, they were somewhat preaching to the choir. Brainstorming solutions, the job landed upon Lukoff and his psychiatrist colleague Francis Liu to attempt to influence the forthcoming fourth edition of the DSM. Their research and advocacy, including in getting support from a minority cultural sensitivity group at the American Psychiatric Association, resulted in the incorporation of the V code, religious or spiritual problem, which operated as a supplement to primary mental disorder diagnoses. Reflecting back 25 years later, Lukoff points to how much of the subsequent discussion around spiritual emergency has concerned how to differentiate a true spiritual crisis from a psychotic break. However, for him, after being invited to speak at mental health peer-run conferences and recognizing the degree of overlap between experiences he heard in these fora and his own LSD-induced spiritual emergency in 1971, his focus shifted to delineating and promoting spiritual competencies for mental health professionals more generally. We can trace right back through the Lang of the politics of experience the question of whose putative psychoses might be better understood as journeys. Inflected by the pervasive use of neuroleptic drugs, the debate often asks who or which subgroups can be rescued. But with psychedelic therapeutics today, there is a potential for a naturalism of a larger nature, to misquote Ursula Le Guin, that seeks not subpopulations but universal principles of healing. Where David Lukoff has come to focus on spiritual competencies, I would like to consider the central place accorded to context, or what gets called set or mindset and setting in contemporary psychedelic therapy. Today's revival of interest in psychedelic therapeutics sits awkwardly with practices for governing and regulating drug treatments that have become established since the first wave of psychedelic research ended around 1970. Even if we grant that the Groff's idealization of psychedelics as amplificatory tools is oversimplistic, the experiences the substances induce are commonly understood to be particularly sensitive to the contexts of their use. The challenges in clinical trial design with respect to unblinding, controlling degrees of freedom in the therapeutic intervention, and measuring the impact of the hype of these much vaunted new miracle cures should help to highlight in stark terms how all drugs are given in psychosocially active contexts. We might in turn note how many psychosocial interventions involve, for example, caffeinated, sugary, or smoked substances. In terms of treatment modality, psychedelic clinical protocols have been explicitly developed to extend beyond the acute phase of the psychedelic trip itself. Consequently, psychedelic therapy might be a good site for rethinking extant drug approval and regulatory processes. The wider context today also includes the spread of spiritual emergency and spiritual crisis networks since the 1980s, which raises interesting questions. Who attends such organizations, networks, and groups, especially given what appears to be a very white, Western, middle-class history of the term spiritual emergency? And what proportion of their experiences were triggered by psychedelics? Would they all have been easily misdiagnosed as psychotic had they been in the wrong place at the wrong time? Are such movements coming under increased pressures to fulfill explanatory and therapeutic roles as psychiatric care is increasingly strained in a post-welfare state context? And to what extent are those in these movements disaffected by psychiatric care, or would many in fact prefer what they may view as a straightforward, organic explanation for their suffering? These strike me as really interesting questions for empirical study, but for the purposes of this presentation, I want to cast the net beyond the spiritual emergency movement to consider grassroots organizing around madness that does not so easily fit into the narratives of spiritual emergence in the Groff's formulation. Such organizing has over the past 2 decades or more extended psychiatric survivor movements and connected them with disability and racial justice movements under broad coalitional banners of mad pride, disability justice, and healing justice. These movements and their critiques of psychiatry today are in many ways well removed from the cultural discontents, both expressed and revitalized through the Langian anti-psychiatry of the 1960s and 1970s. Multimodal causal explanations for people's mental distress are rife, and the forces driving the movements are as much, if not more, political than they are ontological, scientific, or even therapeutic, concerned as they are with oppression, respect, justice, the dignity afforded by autonomy and self-definition, and collective liberation. This cannot be reduced to insisting that madness is meaningful and making spaces for the exploration of that meaning. In these complex heterogeneous movements, over-medicalization is countered by pill shaming, self-determination is preferred over any paternalistic enforcement of the correct treatment, and it is difficult, if not incoherent, to disentangle the fact of the matter from the experience of the matter. As Bridget McWade and colleagues wrote in 2015, the aim is to stop thinking about how we are the same and to begin to work with our differences collectively. It's our hope that building solidarity across experiences of marginalization and disablement can move us beyond defining how we each individually deviate from the norm. Across these movements, we see an embrace of trauma and diagnostic categories, while at the very same time, such terms are demedicalized in the sense that they are being wrested from medical authority and explanatory frames are pluralized. Here we might do well to attend to modes of discernment. How it is that individuals are distinguishing issues with their biochemistry from trauma-related issues, from overly rigid belief systems, from nervous system dysregulation, from relationship issues, from issues with the social or physical milieu, and so on. Switching from explanation to therapeutics, Leah Lakshmi Piepsna Samarasina has written in 2018 of the marginalized and oppressed Black, Asian, and minority ethnic-led healing justice movement. When we asked folks what they did to stay alive, the answers were a rainbow femme quilt of femme emotional intelligence. Meds, Netflix, therapy, prayer, herbs, change, breakups, fresh nails, praying to the ancestors, breaking bottles, finding a friend you can be crazy with, shutting down social media, reaching out on social media groups that felt safe, crying, baths, all the crystals, shit talk. All little things that weren't so little. I suggest we could add the experimental and creative use of psychedelics to this list. In early 2021, I co-organized a conference entitled Psychedelics, Madness and Awakening, Harm Reduction and Future Visions. We explicitly invited psychiatric survivors who did not feel represented in the optimistic, hype-fueled images of psychedelic medicalization. During the conference, a key issue for many speakers was to refuse as epistemic injustices the blanket claims that psychedelics are not for them, and the current doxa that psychedelics are contraindicated in cases of mania, psychotic disorders, and borderline personality disorder arguably has more to do with risk aversion in attempts to re-legitimize the substances through clinical research. Moreover, there appears to be no necessary order in which therapeutic interventions should be deployed. Unlike thinking about drug use as primary or foundational, whether in terms of presenting problems or in terms of therapeutic interventions, the psychedelic revival's emphasis on the pursuit of wellness, curiosity, and joy beyond curing illnesses or healing suffering suggests their use in a much less foundationalist manner. This includes a rethinking of habitual drug use as a pathological endpoint, and even the proposition that the use of at least some drugs in ways that form dependence might even be celebrated when in pursuit of flourishing or the good life. I wonder if the revival of psychedelic therapies is forcing recognition that we both build our everyday practices of living and loving on drug regimens and build drug regimens on top of everyday practices of living and loving. This has been hard to articulate in relation to other illicit drugs, but for various reasons, it's an increasingly vocal point within Western psychedelic using communities. Psychedelics and drugs in general might then be understood as components of wider technical operations. The relevance of the discipline of psychiatry may wane unless it can engage at this level of creative technicity. As Kenneth Kendler has put it, while you can worry about your theoretical reductions, where the world gives us causal traction is critical. And this kind of care might well speak to social psychiatry at its best, collaborative, pragmatic, eclectic. As Peter Sedgwick astutely noted, Langian anti-psychiatry with its cult of immediacy helped to chip away at social psychiatry's provisions. Today's psychedelic therapeutics, with its attentiveness to the context of drug use and its multiple putative mechanisms of effect, including on addressing deep-seated trauma, may help to revivify social psychiatry in a post-Groffian moment where there is a much deeper appreciation of the interacting effects of brain and experience upon one another, and multiple vulnerability models suggest many inroads for therapeutic intervention. Okay. Transpersonal psychiatrist Tim Reed suggests that the term spiritual emergency has always struggled with sounding too new agey and hasn't traveled well outside of the crucible of Esalen. It's self-conceptualized through the study of psychedelic states of consciousness. The idea of spiritual emergency was used to carve space for therapeutic engagement away from an increasingly biomedical psychiatry that had recently seen the publication of the DSM-3, the sort of so-called neo-Kraepelian term. By contrast, today's revival of psychedelic therapeutics emphasizes less the journey metaphor and more the setting, the successful containment and integration of psychedelic experiences. To understand the value of psychedelic experiences for today's grassroots collectives critical of psychiatry, we need to appreciate how psychedelics are being experimented with in the context of plural subjectivities and methodologically eclectic therapeutics. At the intersection of madness and spiritual emergency, the functional organic distinction has gone from being a straitjacketing framework to too simplistic a grammar to be of much use in the underground invention of ever-new mind-body explanatory and therapeutic ensembles. Thanks. That's it. That's it.